Hello coders, and this is part 2 of Radiology Guidelines. We are starting on page 467 in your code book, and this is starting with Diagnostic Ultrasound. Now, remember, Diagnostic Ultrasound requires permanently recorded images. So again, what we need to have a video or static images of what's going on with a written report. So the other things that we need to keep in mind is what it says right up here on the top right-hand side. If less than the required elements for a complete exam are reported, like limited number of organs or limited portion of a region evaluated, the limited code for that anatomic region should be used once per patient exam session. A limited exam of an anatomic region should not be reported for the same exam session as a complete exam of the same region. Okay, so what we're going to see is a lot of guidelines that tell us what is included in a complete exam and what means a limited exam as we're going through. It also tells us that ultrasound guidance procedures also require permanently recorded images of the site to be localized, as well as documentation description of the localization process, either separately or within the report of the procedure for which the guidance is utilized. Okay, so anytime we use ultrasound guidance, it also has to be recorded. So that's the big thing about this. There has to be a physical record, whether it is a virtual record that we can put on a DVD or CD, or a static record that we can print out. We have to have a record of everything they do when they're doing ultrasound. Now again, use of ultrasound without thorough evaluation of organs or anatomic regions, image documentation, and final written report is not separately reportable. So a lot of times when all they're doing when mom is in labor is doing a quick check of the baby's position, and all they're doing is looking, they're not recording that ultrasound image, that is not reportable. Okay, but if we are recording an image for a particular diagnostic reason, we want to make sure that if there is a full record and there is a written report afterwards. So let's go through the different types of ultrasounds that we're going to see. So we have A mode. A mode is a one-dimensional ultrasound measurement procedure. So for instance, we can measure the amount of blood going through an artery or a vein. Okay, but it's just a one-dimensional image. So we're not looking for a 3D image, we're looking for movement. Again, think about movement of blood. M mode is still one-dimensional, but there is movement, and as they call it, record amplitude and velocity of moving echo-producing structures. So M mode, they can start looking at things like our kidneys, our stomach, our lungs, all of our internal structures, because those have the echo producing because they're hollow, okay? B scan is using two-dimensional ultrasounds. So again, we're getting a better display. So for instance, B scan is what we think of normally when we are getting a better understanding about the size of an organ. So again, we're trying to figure out, is the spleen enlarged? How large is it? The B scan will help us with that. The real-time scan is what we're used to when we think of obstetric ultrasounds. The real-time scan is two-dimensional with structure and motion with time. So again, it's happening in real time, all right? However, we also have something called 3D and 4D ultrasounds. Right now, those are still in our category 3 codes, but if a patient needs a 3D ultrasound, obstetrical ultrasound, because of something they've seen or congenital anomaly, that will get paid for by the insurance companies. However, people who are not eligible under their medical necessity for a 3D or 4D ultrasound can choose to pay extra so they can actually get a better view. And what 3D and 4, what 3D ultrasound does is give you full 3 dimensions of the structure. You can see the baby's face, you can see the differences in their fingers. A lot of times, you can see their ears, you can see how long their arms and legs are. 4D is doing the same technology, but in real time. So it's actually collecting all that information, 3D information in real time, and building it in a computer so that it can create a video of the baby actually moving in utero. So we will hear about those from time to time, but really those are more obstetrical procedures. So as we go through, we can see they're separated out by anatomic site. The first is head and neck, which doesn't have any guidelines. The second is the chest. And again, the differences between the complete and the focused or limited. So 76641 represents a complete ultrasound examination of the breast. It consists of an ultrasound examination of all 4 quadrants of the breast and the retroareolar region. It also includes ultrasound examination of the axilla if performed. So again, we separate the breast into 4 quadrants. We have to examine all 4 quadrants, the retroareolar area, so the areola and behind the nipple, and it can go into the axilla. Why? Because a lot of times when we're talking about breast problems, we're talking about possible cancer spreading to the lymph nodes that go under the armpit and the axillary area. However, code 76642 consists of a focused ultrasound examination of the breast limited to the assessment of 1 or more, but not all of the elements listed in code 76641. It also includes ultrasound examination of the axilla if performed. So if we know that there is a mass that is in the lower right-hand quadrant of the breast and we find it, we don't have to go any further. That would be a limited exam. As long as we're not completing all 4 quadrants and the retroareolar area, it's going to be limited. And what I did in my code book, just to let you know the difference, the different colors, I highlighted the codes as well to remind myself which guidelines go with which codes. Then we get to the abdomen and retroperitoneum. Okay, so again, a complete ultrasound examination of the abdomen consists of real-time scans of the liver, gallbladder, common bile duct, pancreas, spleen, kidneys, and the upper abdominal aorta, inferior vena cava, including any demonstrated abdominal abnormality. Okay, so for instance, I don't have a gallbladder, it was removed. But as long as they go through all of those other anatomic sites and say, gallbladder surgically removed 2013, then it can still be considered a complete ultrasound. But again, if we're only doing part of that, it's going to be limited. Now, a complete ultrasound of the retroperitoneum is again a real-time scan. This is the kidneys, abdominal aorta, common iliac artery origins, and inferior vena cava, including any demonstrated retroperitoneal abnormality. Again, maybe something like a kidney stone would be seen. Alternatively, a clinical history suggests urinary tract pathology. Complete evaluation of the kidneys and urinary bladder also compromises a complete retroperitoneal ultrasound. So for instance, if they do see a kidney stone in the left kidney, and that leads them to think that maybe they should continue and check both ureters and the bladder for stones, that is included in the complete ultrasound. But again, it's all or part. If it's all of it, it's 76770. If it's just one part of it, then it's going to be our other codes, 76775. And again, you can see right here, I have highlighted and connected. So the yellow goes with the yellow. Now for obstetrical, you'll notice I use a couple different colors and a couple of different ways of using my colors. So what I've done again is I'm matching up the codes with the actual guidelines. So 76801 and 802 includes determination of the number of gestational sacs and fetuses, gestational sac and fetal measurements appropriate for gestation younger than 14 weeks, 0 days. We also are going to survey visible fetal and placental anatomic structures, qualitative assessment of amniotic fluid, volume, and gestational sac shape, and examination of the maternal uterus and adnexa. So basically, this is when mom is 3 months or less pregnant. Because remember, we go by the last menstrual period, which they calculate as 2 weeks. So they calculate from 2 weeks after the last menstrual period. So for instance, I never got this done because I was 15 weeks pregnant when I found out, and I was 16 weeks when we did the first ultrasound. So this did not apply to me. However, multiples. So if you have twins, you're going to use 76801 and 76802 if mom is less than 14 weeks pregnant. If it's triplets, you're going to use 76801 and 76802 times 2. Why? Because we're doing all the same work on each and every fetus. So every single one of them gets their own separate code. It's up to the insurance company if they're going to decrease the services, but usually they do not, because again, this is part of the package. Now, as we get along in pregnancy, code 76805 and 76810 include determination of number of fetuses in amniotic or chorionic sacs, measurements appropriate for gestational age, older or equal to 14 weeks, 0 days, survey of intracranial and spinal and abdominal anatomy, 4-chambered heart, umbilical cord insertion site, placenta location, amniotic fluid assessment, and when visible, examination of maternal adnexa. So again, by the time we get to about 14 weeks and 1 day, these are the things that we can actually start to see on the ultrasound. Before this point, remember, the neural tube, which creates our nervous system, comes first, and then comes our hands and feet. So when we're less than 14 weeks, we can see some structures, but not much. But by the time we get over 14 weeks, that's when we can start looking at the brain, the heart, and the spinal and abdominal anatomy. Now, as mom continues along, or if we see that there might be any issues, code 76811 and 76812 include all the elements of code 76805 and 76810 plus, so that's everything above, detailed anatomic evaluation of the fetal brain and ventricles, face, heart and outflow tracts, chest anatomy, abdominal organ, specific anatomy, number, length, and architecture of limbs, and it goes on. Detailed evaluation of the umbilical cord, placenta, and other fetal anomaly as clinically indicated. So again, this is when we're looking out for, first of all, making sure that there is a brain and a brain stem, because that is a problem, that is a congenital anomaly. We also can have issues with the heart. We've heard about in the news, Jimmy Fallon's son with the tetralogy of Fallot. It is a series of 4 different heart defects. A lot of times we can start seeing it as we get into, month 6, 7, and 8 of pregnancy. And again, we're looking at, things like number and length of limbs. We're looking at how large the baby is, because again, we have issues like gestational diabetes, which can complicate the pregnancy. And when babies get to a certain size, a lot of times the only option is a C-section, because the baby will not be able to pass through the birth canal. So this is kind of starting that process of, making sure that the baby can go through the birth canal, making sure that we have all the parts that we're looking for. And again, things like cleft lip, cleft palate, they're also looking for. Now it goes on. Report should document the results of the evaluation of each element described above or the reason for non-visualization. So for instance, if we can't see the gender because the baby's legs are crossed, they have to mark that down. Or like what happened with my daughter is she wouldn't move in the right direction, so they couldn't get 2 of the chambers of her heart on ultrasound. So we had to go back a second time. So the first time they had to say we're not able to get left atrium and left ventricle due to baby moving, right? Now, we also have code 76815. This is a focused quick look examination. And again, is limited to the assessments of 1 or more elements listed in code 76815. So 76815 specifically says real-time images limited to things like fetal heartbeat, placenta location, fetal position, and or qualitative amniotic fluid volume. So again, we're looking at one specific aspect. So again, if mom has too much amniotic fluid or not enough, or if there's a heartbeat problem, so one specific little look. However, we also have code 76816, which is designed to reassess fetal size and interval growth or reevaluate 1 or more anatomic abnormalities of a fetus previously demonstrated on ultrasound, and should be coded once for each fetus, requiring reevaluation using modifier 59 for each fetus after the first. Okay? So again, if the baby is very small, or again, if it's a cleft lip, cleft palate, and they want to make sure that they're continuing to see what's going on in the growth, this is the code they're going to use. And then we have code 76817, which is the transvaginal ultrasound. And again, this is performed separately or in addition to a transabdominal examination. Okay, but again, we have a transvaginal for non-obstetrical use. That's coming in one of the next code sets. Okay, so you can see, you know, for my yellows, I marked yellow. Now, again, non-obstetrical, we have to keep in mind, is the woman pregnant or not? Because this is where the code difference comes from. So code 76856 includes complete evaluation of the pelvic anatomy. This includes measurements of the uterus and adnexal structures, measurement of the endometrium, measurement of the bladder when applicable, and description of any pelvic pathology like ovarian cysts, uterine leiomyomata, or free pelvic fluid. So again, we're looking at the muscle layers of the actual uterus itself. We're looking at the adnexal structures. Okay, that's going to be the ovaries and fallopian tubes. We can look at the bladder, and we can also, again, talk about what else might be going on in the pelvic area. We also use the same code for a complete evaluation of the male pelvis. However, examination of the male pelvis includes measurement of the urinary bladder, evaluation of prostate and seminal vesicles to the extent they are visualized. Again, if someone has an enlarged prostate, we might not be able to see the seminal vesicle. And again, they would have to document that. Transabdominally, and any pelvic pathology, again, bladder tumors, enlarged prostates, free pelvic fluid, pelvic abscess. So again, what else do they see when they get there? So again, we use the same code for men or women, but again, they have to fit into these complete categories. Code 76857, again, is a focused examination limited to the assessment of one or more elements that are listed in 76856, or a reevaluation of a pelvic abnormality. So again, keep that in mind. So again, we have our complete versus our limited. We also have the transvaginal ultrasound right here. This is the non-obstetrical. Okay, we don't have any guidelines for the genitalia, but we do for extremities. And they have revised these guidelines because now we can actually do things like use stress, and I'll explain that in a minute. So code 76881 represents a complete evaluation of a specific joint in the extremity. Code 76881 requires examination of the following: joint space, so the effusion itself, periarticular soft tissue structures surrounding the joint, the muscles, the tendons, and the other soft tissue structures, and any identifiable abnormality. In some circumstances, additional evaluations such as dynamic imaging or stress maneuvers may be performed as part of the complete evaluation. Code 76881 also requires permanently recorded images and a written report containing the description of each required elements, and the reason why it could not be visualized, again, because of surgery or trauma. So the big thing, the update here, is the dynamic imaging or stress maneuvers. Because a lot of times we have what we call stress fractures or hairline fractures. They're fractures that the person doesn't feel if they're not putting weight on that part of the body, especially the limbs themselves. You know, a lot of people get stress fractures in their metatarsals, in the top of their feet, and they don't even know about it. They just know that it hurts when they walk. But if they rest their foot, it doesn't hurt anymore. So a lot of times what we do is, if we're not seeing the problem under regular ultrasound, we might have the person put pressure on that part of their body so that we could see what the issue is. So that's the new part of it. Now, code 76882 is a limited evaluation of the joint structures. Again, this is, you know, like a soft tissue mass or fluid collection, or limited to one of the parts of the joint, okay? So again, this is one or more, but not all of the images that we would take for 76681. So that's the thing to keep in mind. You can see down here, this is also revised because again, it now includes the periarticular structures as well as the stress imaging. Now, the ultrasound guidance codes come next. There's no guidelines for those. Same thing for the other procedures and radiologic guidance. What I want to tell you though is if we're using guidance, you can look up the term ultrasound and guidance, or fluoroscopic and then guidance, or guidance and fluoroscopic, and it will send you here. A lot of them are add-on codes, and most of them are used with specific procedures. So I just want you to keep that in mind. So let's talk a little bit about mammograms. So this is page 475. There are no guidelines here, but I want to talk about the differences for these codes. So 77065 is a diagnostic mammogram unilateral, and I wrote for breast abnormalities. These are going to be for masses. This could be a calcification, a cyst, a benign tumor, a lipoma, whatever it ends up being. But this is a diagnostic, meaning we're trying to diagnose the problem. So this is different from the screening. And again, usually what happens is the woman gets a screening first, then she does the diagnostic either later that day or at another time. So again, unilateral, we use RT and LT. If we're doing a bilateral diagnostic mammogram, we just use 77066, no modifier. However, on the top of the page, 77067 is the screening mammogram, and it's bilateral, okay? And this is the screening only. So this is when the woman is just coming in because, she has, she's turned 40 and her doctor says it's time for a mammogram. So we need to be really, really careful with all of this. And again, it says screening right in it versus diagnostic. So again, screening, this is just something that we do to keep everyone healthy. Diagnostic, we're trying to diagnose a problem. Again, our bone and joint studies don't have any guidelines. They're pretty straightforward. But let's talk about radiation oncology. So there's two parts usually to cancer treatment, and that is radiation oncology and chemotherapy. There are other ones. There's immunotherapy as well, which we'll talk about when we do medicine. But most of the time we're doing radiation and chemotherapy because radiation tends to shrink tumors. And number one, when we shrink the tumors, it's much easier to remove. And number two, a lot of times we can shrink tumors with the radiation and then we can kill them with chemotherapy. They complement each other. So the first thing we have to keep in mind is, who are you coding for? Because most of the time, you're not coding for both providers. A lot of times you're coding for the radiation oncologist, or you're coding for the oncology infusion center for chemotherapy. So this is just using different types of radiation to shrink tumors. We have radiation beams, we have external sources where the patient lies on a table or in a machine to get radiation. We have radiation that we can insert into the body and the person can go home and it will slowly leak into their system. And we have radiology that we do intra-procedural, meaning during a procedure, we give radiology at that same exact time. So we're going to go through each and every section. This is starting on page 476. So the first thing is the consultation itself. Okay, so the original consultation can be coded by either evaluation and management, medicine, or surgery, depending on how the radiologist became involved with this particular case. But the first thing they're going to do is they're going to gather up all the testing for the patients, okay, and then they're going to start doing what we call clinical treatment planning, okay? And clinical treatment planning is exactly what it says. It's a complex service, including interpretation of special testing. So special testing is going to be combinations of X-rays, MRIs, ultrasounds, CT scans, PET scans, which are nuclear medicine scans, which we haven't talked about yet. And they're going to blood work. They're going to take all this information, surgical reports. Okay, so they're going to take all the special testing, the tumor localization. So again, finding the tumor itself, treatment volume determination. So how much do they need? Again, is this going to be something over a month or over a year? The treatment time and dosage determinations. How often are they going to come in, and what's the dosage going to be when they come in? The choice of treatment modality. This is going to depend on the radiation oncologist and the cancer the patient has. Certain radiations work better with certain cancers. Okay, it also includes a determination of number of sizes of treatment ports and selection of appropriate treatment devices and other procedures. So treatment ports are what we use to make sure that we are getting directly to the area. Okay, so we have to keep in mind, we don't want the radiation to go into all of the body. So what we do is we get the radiation beam to go directly to where the spot is and no other. However, the more tumors you have in your body, the more complex it gets. So we're going to see these three terms, simple, intermediate, and complex, over and over and over again in the next couple of pages. And so I want you to keep in mind, this is basically how we break it down. Simple means that we have a single treatment area, which is one tumor, okay, and usually we use a single port with simple or no blocking, okay, so we know exactly how we're getting to the tumor, one tumor. Intermediate is 3 or more converging ports, 2 separate treatment areas, so it's 2 separate tumors, multiple blocks, and special time dose constraints. So again, when you're going from 1 tumor to 2 tumors, first of all, is it the same cancer, or is it 2 different cancers? So again, that's partly what we need to keep in mind. Or is it a metastasis, a spread from one to the other? And again, how far away are the tumors? So again, simple because of 1 tumor. Intermediate is 2 tumors, okay? Because now we're getting much more complex. Complex planning is 3 plus tumors, so 3 or more separate treatment areas. We also can use what they call rotational, special beam considerations, or a combination of therapeutic modalities. So again, when you have multiple tumors in your body, they're going to have to, again, take into account, is it the same cancer, 2 different cancers, metastasis, not a metastasis, same organ, different organs. And so again, that makes it much more complex. So the first thing they're going to do is they're going to plan out what's going to happen next. So that's the first part of what they get paid for. Okay. Now, the next part that they do is they do what we call simulation. So this is on the bottom right-hand side of page 476. So again, simulation is the process of defining relevant normal and abnormal target anatomy and acquiring images and data necessary to develop the optimal radiation treatment process for patients. So long story short, it is taking all of their imaging, all of their testing, all of their surgery, and running it through a computer simulation to figure out how is the best way to treat this patient based on the type of cancer they have and where the cancer is located and how many tumors are involved. Now, the simulation is defined as complex, and we are going to see some more definitions, if any of these criteria are met. So if they use particle, rotation, or arc therapy, complex or custom blocking, brachytherapy simulation, hyperthermia probe verification, or any use of contrast materials. So, as well as the definitions on page 477, they're telling us anything that fits into this criteria is automatically considered complex simulation. It goes on to tell us that a treatment area is a contiguous anatomic location that will be treated with radiation therapy. Generally, this includes the primary tumor organ or the resection bed or the draining lymph node chains if indicated. Okay, so an example is a breast cancer patient for whom a single treatment area could be for the breast alone or for the breast adjacent supraclavicular fossa. So that's again going towards the armpit and internal mammary nodes. Okay, so again, where's the cancer, how many tumors, how far is it spread, is it a metastasis? So then we see our definitions again. Simple is 1, intermediate is 2, complex is 3 with any of these others as well. So again, we have treatment planning. We do the simulation along with it to see what the patient needs. Then we're going to get to what we call medical radiation physics, dosimetry, treatment devices, and special services. These are all different types of radiotherapy plans. There are no guidelines for these specifically. So what we're looking for is a type of therapy. So for instance, three-dimensional radiotherapy, basic radiation dosimetry calculation, teletherapy isodose plan, brachytherapy isodose plan. So again, they will have to tell us what they need, what they're doing for the patient so that we know what we need to code for, okay? Same thing is what we call stereotactic radiation treatment. So there are no guidelines for stereotactic radiation treatment delivery. But again, what this is doing is stereotactic radiation is one particular way of getting to a tumor through other body tissues without destroying the other body tissues. So again, it's a very special part. A lot of times they're using these for cranial lesions, lesions in the brain, okay? But again, it depends on what the doctor wants to use. A lot of doctors want to use regular X-ray or photon, electron, neutron, or proton beams. So on the bottom of page 478, it tells us that there are a number of methods. Again, X-ray is photon, and we have what we call IMRT beams, which are a specialty X-ray beam. Electron beams, neutron beams, and proton beams, which are all very common and we've been using for over 50 years now. But it tells us all treatment delivery codes are reported once per treatment session. Okay, the treatment delivery codes recognize technical-only services and contain no physician work. Okay, so again, this is being done by a radiology tech. So this is going directly into the bank of money for the technician fees. This is not going to the doctor, because part of what the doctor does when he's writing all this up is use the information from the technicians. And we have separate codes we'll talk about in a few minutes. Now, first thing to know is radiation treatment delivery with conventional X-rays, that's the MEVs, or electron beams, is assigned levels of complexity based on the number of treatment sites and the complexity of the treatment fields, blocks, wedging, and physical or virtual tissue compensator. So again, we're going to see simple, we're going to see intermediate, we're going to see complex. Now, for skin lesions, we use what we call superficial radiation, okay? And we have a special code just for that, 77401. And again, if we're using this code 77401, we can't use it with any of these others. So a lot of what the guidelines are on page 479 is what you cannot code with. It goes on, third paragraph down, intensity modulated radiation therapy, IMRT, uses computer-based optimization techniques with non-uniform radiation beam intensities to create highly conformal dose distributions that can be delivered by a radiotherapy treatment machine. So again, this is a more complex technology. The doctor would have to tell you they are using image modulated radiation therapy to use these codes. Same thing with the next set. The image guided radiation therapy may be used to direct the radiation beam to reflect motion during treatment. Again, think like lung cancer. We still need to be able to breathe and inflate our lungs. A variety of techniques may be used to perform guidance imaging like ultrasound, CT, MRI, or stereoscopic, and non-imaging like electromagnetic or infrared techniques. Okay, then it goes on and tells us IMRT delivery codes include the technical component of guidance or tracking if performed. So for these two, IMRT and IGRT, they have to tell us this is what they're using. Otherwise, they're going to tell us for the mega electron voltage, okay, the MEV, whether it's simple, intermediate, or complex. They have to state the type of radiation, so that's the first thing to keep in mind. So right up here, radiation treatment delivery is dealt in megavoltage. Megavoltage is big M, small e, big V for mega voltage. Again, simple is a single treatment area. Intermediate is 2 separate treatment areas. Complex are 3 or more. And then again, for the IMRT, simple can be used for prostate, breast, and all sites using physical compensators. Complex is all other sites if not using physical compensators. So again, that's another piece of equipment they would have to state whether they are or are not using it. So again, we need to keep all of this in mind. It all has to be in a report so that we know what they're going to do for the beginning part and then what they are doing at this point for the radiation. Now, while those are tech codes, we have radiation treatment management. So the technicians are the ones who are getting the patient set up, putting them in the machine, doing all this for them. But all of that needs to be documented so that the doctor can do radiation treatment management. So the doctor is not just setting up the treatment. As the patient goes through treatments, they have to do the radiation treatment management, which is checking in with the patient, checking in with their blood work, checking in with the other staff, and seeing what's going on to make sure that the patient is being successful in their treatment. So radiation treatment management is reported in units of 5 fractions or treatment sessions, regardless of the actual time in which the services are furnished. The services need not be furnished on consecutive days. Multiple fractions representing 2 or more treatment sessions furnished on the same day may be counted separately as long as there has been a distinct break in therapy sessions and the fractions are of the character usually furnished on different days. So again, we want to keep in mind that a lot of times people are coming like every other day, or they're coming Monday, Wednesday, Friday, or Tuesday, Thursday. So again, we're going to break out our basic math and count up. For every 5 times they come in, we want to use one of these codes, okay? It goes on and tells us the radiation treatment management requires and includes a minimum of 1 examination of the patient by the physician for medical evaluation and management, like assessing the patient's response to treatment, coordination of care and treatment, and reviewing images or lab test results with documentation for each reporting of the radiation treatment management service. So again, this could be a short office visit, or this could be the radiation oncologist catching up with the patient before and or after their radiation. Okay, now we have one code, 76649, represents only the intraoperative session management and does not include medical evaluation and management outside of that session. Okay, so that is just when we're having someone come in during surgery. Now, the professional services furnished during treatment management typically includes review of port images, review of dosimetry, dose delivery, and treatment parameters, and review of patient treatment setup. So we're looking at, again, making sure that the radiation is getting directly to the tumor or tumors, making sure we're giving them the right dosage. How is the dose getting into their body? Are they succeeding in their treatment, or do we need to change it? And that's part of the review of patient treatment setup. Now, just want to let you know on page 481, there is a lovely table. If you don't want to use the table, you don't have to use the table. But it's a nice table if you want to kind of see how all of these codes work together. All right, the next set on page 42 is the proton beam. So again, we're still getting the same types of guidelines. Simple is a single treatment area. Intermediate is 1 or more treatment areas utilizing 2 or more ports. So again, in this case, we're going by the amount of ports instead of the amount of treatment areas. And complex is 1 or more treatment area using 2 or more ports per treatment area, and using things like multiple isocenters, custom blocks, and compensators. So again, if let's say someone has a nasal tumor, we want to make sure that the rest of the face is cut off from that radiation beam. That's going to be a custom block. Okay, it's going to be like a face mask the patient wears so that all they're getting is radiation just into their nasal cavity. Okay, so again, we need to know that they're using the proton beam. And again, is it simple without compensator, simple with compensator, intermediate, or complex? And again, usually the way to think of it is whatever they decide originally for the radiation treatment planning, it's going to say that. So if it's simple planning, a lot of times it's going to be simple treatment delivery, but always be on the lookout for how they describe it. We can use hyperthermia, so we can use excessive heat to kill cells. So again, this is both for external, which is superficial and deep in the skin, interstitial between the body tissues, and intercavitary in like the abdominal, pelvic, or thoracic cavity. Now, Hyperthermia is only used as an adjunct to radiation therapy or chemotherapy. It may be induced through a variety of sources: microwave, ultrasound, low energy radio frequency conduction, or by probes. So again, we always use this with. So this is not something that's ever going to be done on its own. The doctor might decide to try this along with all of the patient's other therapies. Now, the listed treatments include management during the course of therapy and follow-up care for 3 months after completion. So yes, all of these codes have a 90-day global package. So you can hear superficial versus deep for external. We have interstitial. Here's the intercavitary, right? Then we have something called clinical brachytherapy. This is really interesting. This is when we insert radioactive seeds either into an organ or tumor itself, or put it around a tumor or organ. So the radiation slowly leaks out into the body instead of the patient constantly coming in for radiation treatment. The two most common brachytherapies you're going to hear about is prostate cancer and bladder cancer, but those are not the only ones. Those are just the most successful. So, clinical brachytherapy requires either natural or man-made radio elements applied into or around a treatment field of interest. The supervision of radio elements and dosage interpretations are performed solely by the therapeutic radiologist. They are the ones inserting these, okay, because this is now dealing with surgery. You can see we have some other ones that we can use when it comes to the female genital system. Now, this is different because we're dealing with these little tiny radioactive seeds. We have the simple is 1 to 4 sources or ribbons, so 1 to 4 seeds or ribbons. Intermediate 5 to 10 seeds on a ribbon, or greater than 10. So what I want to do is I want to show you guys the brachytherapy seeds. They're very, very tiny. So I'm just putting in brachytherapy seeds in Google. And what we're going to see is you can fit many of them on a lot of our coins. So we're going to go to images. And again, you can see here in somebody's hand how tiny they are. They're these tiny, tiny little seeds. Okay, you can see here next to a penny, how many, you could fit on a penny. So these little radioactive seeds are either inserted directly into the area, or they're put on a special medical ribbon that's put around the area. And so if it's in the prostate, they put in these needles and then they insert the seeds one by one in rows. Okay, this is specifically for the prostate. Okay, but again, we can also put this around an organ itself. And you can see here, we have a radioactive source in the capsule, and these are very tiny, 4.5 millimeters. So these are really, really tiny. All right, and again, you can see another one right here. See how tiny it is in between this person's fingers. So those are the brachytherapy seeds, okay? So this is, again, patient comes in, they have them implanted or put around their tumor, and then they get to go home. So again, the other thing that we have is we have some high dose brachytherapy, okay? Now, this is something that's interesting. Again, this is going to be used for very specific types of cancer. So high dose brachytherapy involves treatment with radiation sources that cannot safely be handled manually, so not just by hand. These systems are remotely controlled and placed in a radionucleoside source, the radio element or radioisotope within the applicator, and placed in or near the target. These applicators may be placed in the body or on the skin surface. So again, these little seeds themselves, the reason they're inside of the seed is because if we just touch the seed with the radioactivity in it, it would get us very sick. So again, that's what we were looking at when we're looking at what was inside of that seed. Now, they also tell us small electronic X-ray sources placed into an applicator within or close to the target may also be used to generate radiation at high dose rates. This is referred to as high dose rate electronic brachytherapy. So again, new technology that's been coming out. What is your provider doing for this patient? And that's really it when it comes to radiation oncology. So again, the biggest thing is to look under radiation oncology for these. And then what are we doing? Are we doing treatment planning? Are we dealing with therapy, proton, neutron beam? Are we dealing with brachytherapy, which by the way, you can look up brachytherapy by itself. So just keep that in mind. The last set of procedures here connect back to radiation oncology, but also are used completely separate, is nuclear medicine. The difference between nuclear medicine and a normal CAT scan is that instead of putting in a contrast that will just shine brightly so we can see whether or not there's a blockage in a vessel, instead we add in different radioactive isotopes. The different isotopes attach to different cells. So this is what makes it different. So for instance, when it comes to the thyroid, we can actually inject the patient with a radioactive substance that will show us whether the thyroid is overacting or underacting, okay? Because of what the radioactive nucleotide does for us, right? Or the isotope, I should say. But we can also see things like cancer. That's what I was saying with the PET scans earlier. So the PET scans are full body scans where we're actually injecting the patient with a radioactive isotope that attaches to cancer cells. So we can look for things like metastasis, the spreading of cancer. But what nuclear medicine does that other tests cannot do is it can show us function of an organ, physiologic function, like the thyroid, whether it's overacting or underacting. But it can also, again, show us issues like gastroesophageal reflux, or it can help us with bone density, or we can look for gastrointestinal protein loss, vitamin B absorption studies. We can look at our lymphatics and lymph nodes to make sure that they're working properly. We have pulmonary ventilation. And one of the most common that we are going to see is the cardiovascular. But let's just quickly go over this. The radioimmunoassay tests are from pathology, okay? However, the drugs that we use are not included. So, to separately report supply of diagnostic and therapeutic radiopharmaceuticals and drugs, use the appropriate supply codes in addition to the procedure codes. This is when we'd break out HIPPICs and pick the exact radioactive isotope and the exact amount of it that we injected into the patient. I didn't put this picture in, but I want to say one more thing about nuclear medicine before we go. Page 486 has our cardiovascular system, and it says, myocardial perfusion and cardiac blood pool imaging studies may be performed at rest and or during stress. When performed during exercise and or pharmacologic stress, the appropriate stress testing codes from 93015 to 93018 should be reported in addition to these codes. So, this is a test I've actually had a couple of different times. There are different reasons why we do a treadmill or bike stress test versus the myocardial perfusion test. If the person is either unable to run or bike for a long time, then they're not going to get a good enough reading about the heart's movement. The idea is to get the heart pumping as hard and as fast as they can so they can see what happens when you put your body under stress. But certain people's bodies, like mine, cannot get over a certain pulse rate. I just can't get over it. So what they do instead is they inject me with a drug that speeds up my heart rate. And they do their testing, and then they inject me with another drug that puts my heart rate back down to normal. And when we do that, we also have to make sure that we are going to be coding for the drugs, which will also be in HCPCS, as well as the medicine codes that go along with these studies. So let's just keep that in mind. Okay, so again, for nuclear medicine, we look under nuclear medicine. Ultrasound, we look under ultrasound. Radiation oncology, we can look under radiation oncology, or we can look under things like brachytherapy. Always remember, think about what is the type of test we're doing, and then how are they describing it to find our codes in the back of the book. Have a great day.